Hi guys, we're going to talk about chapter 47. This is going to talk about those alterations in immunity or immunologic disorders in our pediatric population. We're just going to go ahead and get started here. So we should be familiar with the types of immunity. We have passive, cellular, and humoral. Passive meaning those antibodies that are received from an external source, mother to baby, IVIG, maybe some of our vaccines. Cellular is those antibodies produced by native T cell lymphocytes, and humoral are those antibodies produced by those native B cell lymphocytes. So just be familiar with those immunities so that it can make sense as we move through this chapter. Some of the variations that we might see in our pediatric anatomy and physiology is that newborns do receive that passive immunity from that maternal antibodies via the placenta and breastfeeding. So remember, that's that passive. It comes from an external source. The newborn exhibits a decreased inflammatory and phagocytic response to invading organisms, which just makes them more susceptible to infections. They do have an increased susceptibility to infection. They have a functional spleen and generally a functional cellular immunity. Humoral immunity does develop over time. As we are exposed to different things, it's going to build that immunity system. And then the last variation is that young child has very large lymph nodes, tonsils, and thymus compared to the adult population. So let's start with our assessment of our kiddos with immunodeficiency, autoimmune, or allergies. And we're going to start with that health history. We're going to ask questions about maternal HIV infections. Do they have frequent recurrent infections such as otitis media, sinusitis, or pneumonia? Does our patient have a chronic cough, recurrent fever? Do they have 2 or more serious infections early in their childhood? Is there extensive eczema or growth failure? That's going to give us, all those questions are going to give us a really good health history and an assessment regarding some of these disease processes. As far as family history, it could be positive for immune deficiency or autoimmune disorder. It could also be negative. This may not be anything that they know about in their family history. And then physical examination. Let's look at that here. So we know we're going to do least invasive to most invasive. So we're going to inspect and observe. We're going to plot that weight, length, and height on appropriate growth charts so we can see those trends. We're going to look at the tonsil size. We're going to note any eczematous or other skin lesions which could occur with an allergic disease process. We're going to document the presence of any thrush, which is very frequent in children with our immunodeficiencies. And we're going to observe their gait. Neurological alterations occur with HIV infections. So if we're seeing gait changes, that would be concerning for us. Then we're going to auscultate, percuss, and palpate. Auscultate those lungs. We're listening for any adventitious sounds. Wheezing could indicate allergic reactions. We're going to percuss that belly and determine that liver span. And then we're going to palpate any enlarged lymph nodes. Some of the common labs and diagnostics that you might see are the CBC, or your complete blood count, with that differential. That's going to indicate infection, inflammatory process, maybe immunosuppression. Immunoglobulin electrophoresis is going to detect immune deficiencies and autoimmune disorders. IgG subclasses can help determine immune deficiencies. Virology assay for HIV, RNA, or DNA. This is our true diagnostic of HIV infections in children older than 2 weeks of age. Erythrocyte sedimentation rate, or ESRs, are going to help with our immune disorders. Rheumatoid factor might help with our juvenile idiopathic arthritis. The ANA, or anti-nuclear antibody, It may help detect juvenile idiopathic arthritis or systemic lupus. Our RAST, you've probably heard of, is that skin test to help with asthma or food allergies, and then allergy skin testing, again, for allergic rhinitis or possibly asthma. Some of the common medications and medical treatments that we might see are immunosuppressants, cytotoxic medications. Those cytotoxic medications can interfere with normal function of DNA. Those might be our chemos. Corticosteroids are anti-inflammatories used usually for juvenile idiopathic arthritis and maybe our systemic lupus. Intravenous immunoglobulins, or IVIG, helps provide exogenous IgG antibodies. It's usually indicated for primary immune deficiencies and HIV infections. Anti-malarial drugs help prevent flare-ups in our lupus and our juvenile idiopathic patients. Disease-modifying anti-rheumatic drugs kind of depletes those DNA precursors and is used in our juvenile idiopathic. Antiviral medications bind to that HIV-1 reverse transcriptase, and it blocks the DNA polymerase activity, which helps disrupt the virus life cycle of our HIV patients. Immunizations should be very familiar, helps prevent viral and bacterial infections. Remember that we cannot give live vaccines to those that are immunocompromised. And then bone marrow or stem cell transplant. Bone marrow transplants transfers healthy bone marrow into the bones of a person with an immune malfunction. Stem cell transplants comes from a donor or umbilical cord or placenta. So after we've done our thorough assessment, some of the priorities for our patient might include infection or risk of infection, alteration in nutritional status, altered tissue integrity, activity intolerance, delayed growth and development, and pain. So let's look at some of our primary immunodeficiencies. These are mostly hereditary or congenital, and they're usually related to humoral deficiencies, cellular immunity deficiencies, a combination of those, phagocytic system defects, or complement deficiencies. So those are your C3, C4 labs. What are some warning signs? Those are listed there. I'll name off just a few of them here. If they've had 4 or more new episodes of acute otitis media in a year, maybe 2 or more episodes of severe sinusitis, failure to thrive, persistent thrush, history of infections requiring IV antibiotics, family history. All of those would be just really big warning signs that your patient may have a primary immunodeficiency. So what are those primary immunodeficiencies? We can think about hypogammaglobulinemia, Wiskott-Aldrich syndrome, and severe combined immune deficiencies. I'm not going to go into a lot of details with these. I just want you to be aware that these are your primary immunodeficiencies. So what are some of the causes of secondary immunodeficiencies? These are going to occur as a result of chronic illnesses, malignancies, the use of immunosuppressive medications, malnutrition, prematurity, and HIV infections. And our focus for this chapter is going to be that HIV infection. So 3.2 million children younger than 18 years are living with HIV. Children acquire HIV vertically or horizontally. You can see vertically acquired patients are that perinatal, so they're in utero or during birth. It could be via breast milk. It's usually referred to as that mother-to-child transmission. Horizontal acquired is transmission via non-sterile needles or sexual contact. Infants primarily become infected through their moms, which is vertical. Adolescents primarily become contracted through sexual activity or IV drugs, which is horizontal. The virus replicates itself via the CD4 cells, which cause just dysfunction in those cells. B cells defects also occur and contribute to high rates of serious bacterial infections. Opportunistic infections occur because of those T cells and B cell deficits. Progressive HIV encephalopathy in children advance that neurological symptom, and usually that's going to occur before that immunosuppression happens. So watching those gates is very important. Some common signs and symptoms that are reported are failure to thrive, recurrent bacterial infections, opportunistic infections, chronic or recurrent diarrhea, recurrent or persistent fever, developmental delay, and prolonged candidiasis. Medication therapy for children include antiretroviral drugs. This medication regimen can range from a single dose therapy if they're asymptomatic, exposure to highly active therapy when they are symptomatic. The more progressive the HIV, the more issues that are with that brain. So encephalopathy, neurological issues, again, are going to be seen sooner than later. So after we've taken a thorough history, we'll do our physical exam, and that's going to be completed doing inspection and observation first. So we're going to inspect and observe our patient. Are there any fevers that have been noted? We're going to measure our infant and plot them on that growth chart so we can see that baseline measurement. We also need to determine that level of consciousness. They could be alert or oriented or depressed if HIV encephalopathy is present. Some labs and diagnostic that I want you to be aware of. The PCR, the polymerase chain reaction, is a positive in infected infants older than 1 month of age. So if we're testing our patients less than 1 month of age, this test is not super effective. Our enzyme-linked immunosuppressant ELSA test is positive in our infants infected by mothers transplacentally. So these antibodies may persist and remain detectable up to 24 months of age. If we're younger than 1 month of age, we can test, but if it comes back negative, we've definitely got to wait for that 1 month age mark. And that PCR is our gold standard test. The ELSA test is less accurate than the PCR, but just know that both of those tests are available out there. So nursing management is directed at preventing or reducing the infection. Infants born to moms infected with HIV are going to receive zidovudine, which is a 6-week course of medication. We're going to discourage our mothers from breastfeeding because we now know that HIV can be passed through the breast milk. This could be a very big ethical issue, unfortunately. We want to promote compliance with medications, making sure that we're preventing any progression of HIV disease and that encephalopathy. We're going to promote nutrition, increased calorie formula for our infants, high calorie, high protein meals and snacks for our children. We're going to educate the patient, we're going to provide pain management and comfort measures, and then we're going to educate that patient and families, making sure that we're educating our adolescents about safe sex practices, using condoms with each encounter, remembering that live vaccines cannot be administered to those immunosuppressant patients. So what are some of the stressors that are involved with kiddos that are diagnosed with HIV? We have to remember that this is a lifelong chronic problem. Diagnosis is an incurable disease, and it's going to put a lot of stress on that family. They may find financial difficulties because the medication regimen can be very expensive. And we know that HIV can come with some stigmas. The desire to keep that HIV infection confidential. So sometimes the big stressor, the other big stressor with families is, when do we tell the children, right? If it's a patient that's born with HIV, at what point do we tell them about this diagnosis? Additional family medication that we can think about is, again, that medication regimen and making sure that they are staying on top of it to help in the progression of the disease process. There's going to be ongoing follow-up, so we need to make sure we're reassuring our family when to call the provider. All right, so let's move into autoimmune disease. Autoimmune disorders result from the immune system's malfunction. The body is manufacturing T cells and antibodies against its own cells and organs. And some of those factors that influence these autoimmune diseases are hereditary, hormone, self-marker molecules, and then those environmental influences, including viruses and certain drugs out there. Autoimmune disorders are systemic lupus erythematosus, juvenile idiopathic arthritis, Guillain-Barré, myasthenia gravis, and dermatomyositis. Sorry, guys. The two that we're going to focus on are the top two, your SLE and your JIA. So systemic lupus is a multi-system autoimmune disorder. It can affect any organ system, meaning the onset and the course can be very variable. It's rarely diagnosed before age 1. We're going to get a really good assessment, including a health history. So we're going to discuss present illness, chief complaint. We're going to do a physical examination, checking for temperature. Do they have a fever? Observing skin for that malar rash, documenting any alopecia, inspecting oral cavities for painless ulcerations, and joints for edema. The most common clinical manifestations are listed here. I'll let you read through each of those. Just be aware, alopecia is a huge one, fatigue, photosensitivity, and those skin rashes, particularly characteristics of a malar skin rash, which is, this is the classic symptom of lupus. You can see that butterfly-shaped rash over their cheeks. And then the last thing we'll do is get some labs and diagnostics. When we get those, we're going to see a decrease in hemoglobin and hematocrit, a decrease in our platelet count, and our white blood cell counts will also be very low. So how do we manage systemic lupus? This is a long-term and supportive. Management's going to focus on prevention and monitoring of complications. And this is going to include talking about application of sunscreen daily to prevent rashes that result from photosensitivity, instructing children to protect themselves against cold weather by layering up. If they're playing out in the cold for a long period of time, we may need to inspect the fingers and toes for discoloration. We also want to frequently check their blood pressure, teaching to check urine output, and monitoring for hematuria or proteinuria. Education for patients and families is going to be huge. The biggest thing is diet needs to be healthy. They also need regular exercise and adequate sleep. And then there will be some medications that get administered, our NSAIDs, corticosteroids, and anti-malarial agents with our mild to moderate SLE, and then with a step up to immunomodulators with those with severe or frequent flare-ups of their SLE. Juvenile idiopathic arthritis is an autoimmune disorder that mainly targets the joints. Inflammatory changes cause pain, redness, warmth, stiffness, and swelling. Juvenile idiopathic arthritis is formerly known as juvenile rheumatoid arthritis, which you guys were probably more familiar with. We changed the name because of the fact that rheumatoid factors don't usually come into play with our pediatric population. You can see the different types of JIA on your screen there, and this came right out of your book. So the different types are polyarticular, which just means there's 4 or fewer joints are involved. This is the most common type. Polyarticular, meaning 5 or more joints are involved. These are usually small joints and they affect the body symmetrically. And then systemic is that last type. Not only is joint involvement, but they usually have fever, and rash can also be present for their diagnosis. So nursing management is going to focus on managing their pain. We'll do medication prescriptions for inflammation and prevent disease progression. We're going to maintain their mobility. Physical and occupational therapy is warranted to help with range of motion and muscle strength. Swimming is very useful exercise to maintain joint mobility without placing a lot of pressure on those joints. And the last management is promoting just that normal life. Remember, this is a chronic illness with a lot of chronic pain, and it's going to impact a child's psychological and emotional status significantly. We want to encourage plenty of sleep or rest so that that child has the ability to cope with their school functions. And we want to encourage support groups and special summer camps to help children see they aren't alone in this disease process. All right, let's move into food allergies. This affects approximately 8% of kiddos. A true hypersensitivity of allergy is defined as an immunological reaction. The most common food allergens in the first few years of life are milk, eggs, peanuts, tree nuts, fish and shellfish, wheat and soy, sesame seed, and kiwi fruit. Peanuts, tree nuts, fish, and shellfish will typically persist into adulthood. These allergens can occur within minutes of exposure to a couple of hours after ingestion. Signs and symptoms that you might see are hives, flushing, facial swelling, mouth and throat itching, runny nose, GI reactions. In those very extreme reactions, you may see swelling of the tongue, uvula, pharynx, or upper airway. So how are we going to take care of these patients? Management's going to include verifying that food allergy, making sure that we're discerning a true food allergy from an intolerance. A lot of times kiddos will say, or parents will say that their kids are allergic to milk, and it's not really an allergy to milk, it's more of an intolerance to lactose. So making sure we can discern those true allergens. We want to avoid the allergen, so removing it from their diet, and we may need to treat the reaction. Antihistamines and epinephrine are your drugs of choice. Nursing management is going to include assessing the airway, breathing, or circulation problems. We're going to allergy skin prick test them, or that RAST test. Testing could have false positives, which lead to children avoiding foods unnecessarily. Food-specific IgE is highly recommended with any history of food allergies. We may do an oral challenge, which means we're slowly eating that food allergen over the course of an hour and monitoring the presence or absence of any symptoms. And then we may do trial elimination diet. So we eliminate the food from the diet for 1 to 2 weeks, and then we retry that food one at a time and watch to see if similar reactions do occur. Anaphylaxis is an IgE-mediated response to an allergen that involves many organ systems and could be life-threatening. If more than one immunologic reaction is occurring in different systems, then anaphylaxis needs to be considered. So if we have a patient with nausea and vomiting with airway constriction, then we know that's a GI system and a respiratory system. If they have airway constriction and hives, then we know we have a respiratory system problem and an integumentary problem. So 2 different systems are being considered. Anaphylaxis should be on our radar. Therapeutic management is going to assessment and support of airway, breathing, and circulation. We may do some epinephrine, which will be required if 2 of those systems are involved. That could be an EpiPen or an EpiPen Junior. Once we have this diagnosis, then those children will be carrying those with them everywhere they go. And then we may follow up with intramuscular or intravenous Benadryl. So again, nursing management for anaphylaxis, supplemental oxygen if we have airway constriction. We're definitely doing that epinephrine to reverse the allergic reaction response. Bronchodilators if they're having bronchospasms. So if we have bronchospasms present, we're going to use that bronchodilator. We'll give IV fluids. We're going to observe for 2 hours after we do that epinephrine or that epi to make sure they don't have any bounce back or recurrent attacks. So this is just the use of the EpiPen or EpiPen Junior. It's a pretty simple technique to teach your patients. The biggest thing is that it can go through clothing, so don't take the time to take clothing off, just get it in their system. And then the last one I want to just touch on is a latex allergy. This is an IG-mediated response to exposure to latex. The medical field has gotten really good about getting latex out of a lot of their equipment. It can result in anaphylaxis. And sometimes it's an allergic symptom after eating some type of food that may have latex in that. So pears, peaches, kiwi, grape, cherry, melon, banana, avocado, celery, tomato, potatoes, and plums all have latex. So if you're seeing allergic symptoms, you have to be on guard with that latex with those foods. We want to assess for hives, wheezing, cough, shortness of breath, and nasal congestion. And that concludes chapter 47. If you have any questions, you can shoot me an email or we can chat about it in class. Thanks, guys.